Our next speaker is Mark Topazian from the Mayo Clinic, Rochester. He will be covering a topic titled Endoscopic Management of PSC. Is ERCP helpful? Mark.
Thank you, and I'll say what others have said this morning. It's a great honor and privilege to be talking to you today, and I appreciate the opportunity. So my topic, as was mentioned, is endoscopic management of PSC. Is ERCP helpful? And the bottom line is I'm going to give you a qualified yes. I'm going to say that ERCP is helpful, but only when there's a clear rationale for doing this procedure. And many people with PSC will not require ERCP. So I want to start by just explaining what ERCP is. It stands for endoscopic retrograde cholangiopancreatography, and this is an endoscopy. It's done in the U.S. in almost all centers now with the patient under deep sedation or anesthesia. So this is an invasive procedure with an endoscope through the mouth, but the patient really shouldn't feel anything of what's done during this procedure. An endoscope is passed through the mouth, through the stomach, onto the duodenum here. This is the C-shaped structure here is the first part of the small intestine called the duodenum. And an endoscope is used where the operator has a view out the side of the tip of the scope. And so they can see this spot right here, which is called the papilla. And this area is where two ducts enter the intestine. The bile duct in green here, which is coming down from the liver, which is not really shown on this particular image, and also the pancreas duct. This yellow structure here is the pancreas, and it's draining pancreas juice into the intestine right at the same spot. And so the endoscopist can see that place and put a catheter into that area. And the endoscopist can get pictures of the bile duct. So in this cartoon here, showing the biliary tree, well, you can see why we do call it a tree. There's the trunk, which is the common duct, the common bile duct, and then in the liver there are branches, and typically there's a branch here, the left hepatic duct going to the left lobe of the liver, and two main branches going to the right lobe, right anterior and right posterior. And each of these three main branches in the liver drains about a third of the liver tissue, drains bile from about a third of the liver tissue. And this is what these ducts look like during an X-ray taken during ERCP. So here an endoscope is going down through the stomach, and actually the duodenum is off the bottom of this image, and a catheter has been passed up into the bile duct through the papilla, and then here's an injection of contrast, liquid with iodine in it, which blocks X-rays, and showing the left duct and right anterior and the right posterior duct. Now, during ERCP, besides getting pictures of the bile duct, certain interventions are sometimes performed. And in this cartoon on your left, there's a device called a papillotome placed here that it can be used to actually cut open the papilla, and which is sort of the choke point for the bile duct here, to enable, for instance, removal of a stone. And in this cartoon, and all these cartoons are from the American College of Gastroenterology website, this shows a balloon catheter that's been placed over a guide wire here and inflated to dilate a narrow place in the bile duct. And then another intervention which may be performed is placement of a stent. And in this cartoon, there's a blue structure here, a blue piece of plastic tubing going from the papilla up the bile duct up to here. And in this particular illustration, this doesn't have to do with PSC. It's showing the stent relieving blockage of the bile duct caused by a tumor in the pancreas in this example. Now I'm going to show it a video of what the endoscopist sees during ERCP. And if you're squeamish about medical footage, maybe you don't want to watch this. But I thought that I would show it anyway. So this is, for those of you who like this kind of thing. So this is a view of the major papilla seen through a side viewing endoscope. And let's see what I need to do to get this to play here. maybe I'll stop the laser pointer and see now. There we go. So this is the major papilla, and this is that papillotome device, which is going to be placed into the opening of the major papilla by the endoscopist. And then a guide wire is passed through that device up into the bile duct, and also some contrast material injected. And this shows an X-ray, and there's some tiny white dots in the bile duct there that are little stones, actually, in this case. There's a picture of some more of the ducts. And then the endoscopist is going to cut open the major papilla, and this is called sphincterotomy or papillotomy. And of course, the patient is under anesthesia, but even if they weren't, they wouldn't actually feel this, which is maybe hard to believe, but it's true. And this sort of opens up that narrowing at the bottom of the bile duct, which may be scarred and stenotic and a limiting flow in some people. And then stones can be removed. And oftentimes we put a catheter with a little inflatable balloon on the end up into the bile duct to sweep out the stones. In this particular case, the stones can even just be sort of milked out of the bile duct with this papillotome device. So what is the role of this test, ERCP, in sclerosing cholangitis? Well, there's a number of potential applications. One is diagnosis. As you've heard already today, PSC is a disease of the bile ducts, and so it's probably the single best way to get a picture of the bile ducts. Now, I would agree with Gideon, who said that usually MRI is enough, and he's absolutely right about that. But there's occasions where it's not so easy to tell what's going on, and a high-quality picture of the bile ducts makes a difference in the diagnosis, and sometimes also in distinguishing diseases that mimic PSC from PSC itself. There's also a role in tissue sampling, so taking what are called brushings or biopsies from the bile duct, even looking up with a baby endoscope right into the bile duct to direct those samplings, and that can be useful to look for pre-malignant or malignant changes in the bile duct. And then finally, treatment of biliary complications of PSC, and you've already heard about this some today, but these interventions such as sphincterotomy, which I just showed you, removal of stones, dilation of strictures, or stent placement. Now, here's a picture of I'm going to turn the pointer back on here. Here's a picture of an endoscopic cholangiogram in PSC to make a point about diagnosis. So on this side is that normal cholangiogram, which I showed you earlier, from a person without PSC. And over here is a picture of the right hepatic ducts in someone with PSC. And I want you to just look at those and see what, if you see any differences. I think the first thing that strikes my eye is I just see more small bile ducts in this picture than this picture. And we call this pruning of the biliary tree. So there's some small ducts that you don't see. And they're probably there, but between swelling of the lining of the bile duct and scar tissue compressing these ducts, there's just fewer bile ducts in someone with PSC that are visible on this test. And then if you look carefully at these small ducts, you see strictures. And so right here, and right here, and then here's a stricture over here. This laser pointer is a bit too big, but the more you look, perhaps the more strictures you would see in this picture. And so this presence of multiple strictures in different locations in the bile ducts is a hallmark of PSC. Now, the point was made about MRI, and this patient also had an MRCP, and here is their MRI picture. This is the gallbladder, this big white thing, and you have a little bit of gallbladder on the ERCP also. But if you look up in the ducts in the liver, you might say, yeah, I see some strictures here, and this is PSC diagnosed by MRI, but the endoscopic cholangiogram shows more detail. And sometimes, certainly not always, but sometimes that's useful. This is another example of what PSC might look like. And in this case, the bile ducts, the lining of the bile ducts looks very irregular. It's not a smooth edge to the ducts, it's a bumpy edge. And sometimes this is even called beading, because physicians have said that this can look like a string of beads on a necklace, these little, the variation of narrowing and widening along the duct here, and perhaps if you use your imagination here. Here's another cholangiogram, endoscopic cholangiogram from someone with PSC, and this shows what we call filling defects. So here the radiographic contrast, which is dark, has been injected into the ducts of the right lobe and the left lobe. And up in here, there's some white areas that don't fill with the contrast. And these are actually stones in the bile ducts in the liver. And there's several of them along here in the main right duct and several along here in the left duct. Now, so far I've been showing you what the bile ducts in the liver look like, but this person with PSC also has some findings in the bile duct outside of the liver, the main bile duct, or the trunk of the tree, draining the bile to the intestine. And here's the endoscope in that C-shaped duodenum. Here's a catheter in the papilla, and there's a narrowing right here at the bottom of the bile duct. And then this main bile duct has a somewhat irregular caliber. And then finally, one of the things we often look for is what we call pseudo diverticula of the bile duct. And if you look along this bile duct, it has a very irregular outer edge. And there's some impression of little pouches coming off of it. And these are probably actually ulcers in the lining of the bile duct from the inflammation there. And this feature, when it's seen, is very helpful in distinguishing PSC from some disease mimickers. Now, you've heard the word dominant stricture a lot today in some of the conversations. And what it's a word that means many different things to many different people. But what I would refer to as a potentially flow-limiting stricture in the bile ducts. And here's an example of a person with PSC who's having an ERCP. Here's the endoscope coming through their stomach down to the duodenum. And then here's a catheter in the bile duct. And there's a balloon inflated there on the catheter, and contrast has been put up in the bile ducts. And in both the right duct and the left duct, there are narrowings that seem longer and tighter than many of the other narrowings in this person's biliary tree and are potentially flow limiting. And that's what your doctor may mean when they talk about a dominant stricture. It doesn't mean that that stricture is a cancer, although some take that word to mean cancer, dominant. In fact, most so-called dominant strictures are benign and inflammatory, but it needs to be sampled, but it may also need to be treated, especially if it's causing symptoms. And here's an example of how a dominant stricture is treated. This person with PSC has a narrowing, what appears to be a flow-limiting narrowing right at the bottom of the main bile duct, just as it approaches the intestine. And the main duct is a bit dilated as a consequence. And in this example, a balloon has been put there, and I don't know how well it projects, but this is the balloon catheter. It's been inflated with contrast material so you can see it there, and it's stretching this narrow place. And then after the balloon is deflated, we inject contrast again in the bile duct, and it pours out very readily through this now open area into the intestine and around the endoscope. So this is balloon dilation of a stricture in sclerosing cholangitis. Now, besides balloon dilation, stents can be put in the bile duct. And this picture shows an example of some sorts of stents. They tend to come in either, we call them plastic or metal. And the two on the left are plastic stents of different caliber. This one has curls on either end, sometimes referred to as pigtails. And those help keep the stent in position across a narrow place. This straight stent has some flaps on it that help keep the stent in position. And these plastic stents clog over time, silt builds up in them, and they have to be removed. But they're easy to remove, and they're a temporary sort of thing. These stents are made out of knit metal wires, and there's many varieties of metal stents. These are placed, they're kind of like those finger puzzles you may have played with when you were a kid, where you could put your finger in and you couldn't get your finger out. They come long and thin and constrained on a catheter, and the endoscopist puts them in the bile duct and releases them, and they get short and fat and really have a much larger caliber than the plastic stents. The problem with these, if they're uncovered, they embed in the bile duct wall and are there permanently and create inflammation and problems. And so really uncovered metal stents have really very little role in PSC, and even the covered ones, which can be removed, have a very limited role. And at least in our practice, if we're going to use a stent, you always use one of these plastic stents instead. So let's go back to this example of someone with these potentially flow-limiting strictures of the central right and left hepatic ducts. And here's an example, here's how this patient was treated. So we inflated a balloon in the left duct and the right duct, and you can see on these balloons what are called a waist. And what that means is we inflated the balloon, and the center of the balloon, right in the tightest part of the stricture, wouldn't open up all the way. So the balloon looks like it is an hourglass. It's got a waist in the middle of it. And that's a sign that the stricture is really somewhat resistant to dilation and is not going to open up fully. And so in this particular patient, we put those plastic stents. And here they are. Here's the ends in the duodenum. And then they go up. One stent goes into the left duct and the other into the right duct. And you notice there's no contrast anymore up in the liver ducts, and that's a good sign. It means it's all drained right out through the stents into the intestine. And of course, that's our goal, is to get the bile draining well. So what are the indications for this sort of invasive treatment of the bile ducts in sclerosing cholangitis? Well, one would be what's called bacterial cholangitis, and this is a bacterial infection in the stagnant bile, and it's an infection that can spread through the liver tissue to the bloodstream. Typically presents, as some of you know, with a high fever, a shaking chill, often with jaundice, sometimes with pain, and it can be a life-threatening sort of infection. The treatment involves antibiotics, but it may also involve some intervention to relieve blockage of the bile ducts. And this is what you may see during ERCP in cholangitis. This is the major papilla with a guide wire going into the bile duct, and there's pus streaming out into the intestine. Another indication for ERCP in PSC would be jaundice. And jaundice, of course, in PSC could be from the liver cells not being adequate to do their job, and it could be a sign of failure of the liver, but often it's a sign of blockage of the bile ducts instead. And so jaundice may be an indication. And then pain, some would take to be an indication for ERCP. I have much less certainty about that one, but in some cases, perhaps some role. So does ERCP done for these indications really help patients with PSC? And here's some of the information we have. This is a paper from colleagues at the Virginia Mason Medical Center, and this graph is similar to many other graphs you could find in the medical literature. So this is one of those Kaplan-Meier curves we've been seeing all morning. And I just want to review that on the y-axis here, the vertical axis is the proportion surviving without liver transplant. So of course at time 0 it ought to be 100%, because everyone at time 0 was having their procedure and hadn't had a liver transplant. And then this is the survival without liver transplant over the years, in this graph up to 4.5 years on the x-axis. And the researchers have drawn two lines here. The solid line is the observed survival without liver transplant, and even at 4 years, it was about 85% of their patients who had ERCP for one reason or another were alive without a liver transplant after 4 years. And then they said, okay, well, how would they have done if we hadn't done the ERCP? And they tried to predict what would have happened to those people. And they said, well, they would have done worse. They would have had a survival without liver transplant of only about 70%. And they used a multifactorial scoring model to try and predict how their patients would have done. And there's some problems with this sort of analysis. The ability to predict how people will do is not as accurate as one might like. And some of the scoring features that are used are impacted by ERCP, such as the bilirubin level. And so this is sort of the level of evidence we have that ERCP is helpful. We were interested in this question in my place at Mayo, and last year did a study where we asked this question specifically about PSC patients who were jaundiced. We thought that cholangitis was a rather clear-cut and separate issue, but we said, what about jaundice? Does ERCP really help in that situation? And if you do an ERCP, what happens? So we looked at a large group of patients at our place with PSC who were jaundiced, who were sent to our place for evaluation. And what you have here again is the cumulative, in this case we've sort of turned it upside down, so it's the cumulative incidence of death or liver transplant over time. So at the start no one has died or had liver transplant. And then we had somewhat longer follow-up up to about 10 years. And we said, well, if we took these people with jaundice who had an ERCP and had dilation of a stricture or placement of a stent, how did they do? And we didn't try to predict anything. We looked at those whose jaundice resolved and those whose jaundice did not resolve. And we said, what happened? And so those whose jaundice resolved are in the dotted line, and they had a lower chance of dying or needing a liver transplant than those whose jaundice did not resolve. And we further found that there were certain endoscopic variables that help predict whether someone's jaundice went away after ERCP. For instance, whether all those ducts in the liver were visualized or not, the size of balloon that was used to dilate strictures, and so forth. So we take this as some evidence that endoscopic intervention to help relieve jaundice may be helpful in some people with PSC. But we still don't have what you would consider gold standard evidence about this, or irrefutable evidence about this, such as from a randomized controlled trial. Now, there are risks in ERCP, which I'm just going to briefly touch on. The main risk is pancreatitis and painful swelling of the pancreas, which, as I showed, drains its juice into the intestine right with the bile duct. And especially with the first ERCP, there's a significant risk of that. It can be lowered by using medication suppositories that are given during the procedure, sometimes lowered by putting a temporary stent in the pancreas duct during the procedure, but the pancreatitis is an issue. There are smaller risks of bleeding. There's a risk of infection, and particularly in PSC, and the blocked small ducts in the liver are a risk, and when ERCP is done in a person with PSC, they should really be on some antibiotics afterward for a period of days to try and prevent infection, and a very small risk of making a hole or tear in the intestinal tract. So what is the role of ERCP? John Eaton earlier showed puzzle pieces, and I would say that ERCP is one of the pieces. It's part of the armamentarium or the tools that your doctor has to try and help you have the best outcome with PSC. So that's my conclusion, and thank you very much.